the title I was given was to sort of review anatomy of the heart from Leonardo da Vinci to 3D. Well, I should start from the outset and say that declare I'm not an art historian and I'm not a medical historian. I'm a simple, very simple, small anatomist who happens to love dissecting, examining, and researching hearts, especially congenitally malformed hearts and hearts with conduction disturbances. So here I am having to tackle this title, Anatomy of the Heart from Leonardo da Vinci to 3D. And I think you all know Leonardo da Vinci from having seen his beautiful paintings from all over the world. Leonardo was born in a small hilltop town that runs on the road between Florence and Pisa. And he's very, very well known for his beautiful paintings for the general public, of course. But for the medical people, I think Leonardo is actually a very good starting point for talking about cardiac anatomy because he was the first to sort of refute Galen's doctrines of a heart having two ventricles. He came up with the proposition that the heart has four chambers, two upper ventricles, which later became called the auricles, and two lower ventricles. So I turned then to Kenneth Keel, who was a Leonardo scholar, and he wrote in his opening paragraph of this paper, Leonardo was the man who awoke too early in the darkness while all the others were still asleep, and his gigantic efforts in the realm of what we now call science tragically failed to disturb his fellows from the slumbers, and only by his painting did he rouse them to their senses. And how very true that was. Because of Leonardo's known manuscripts, more than 5,000 pages of manuscripts, largely they were based on mechanics, because Leonardo was one of the few artists in the Renaissance period who was interested not only in the form of the human body, but also, and especially, in the function of different parts of the human body. So he examined bones and muscles and worked out how they worked. And 190 pages were devoted to anatomy, 50 on the heart, which is about 1% of all the manuscripts that survived to current day. And I'm sure you're all familiar with this sort of picture taken from Leonardo's works. And in fact, I should say that Leonardo's anatomical works were mainly based on animal dissections, because in those days, there was sometimes interference from the church, there was difficulties in getting human bodies or human cadavers for dissections, and added to that the practical aspect of dissecting on decomposing bodies, the smell of it, especially during the summer period. So he resorted a lot to animal dissections, and these are depictions of bovine hearts that he dissected, and you will notice the auricles or appendages are really quite similar looking, which is the case, unlike in the human situation. And also, he did a lot of experiments on looking at how the heart works. Although he was dealing with cadaver hearts or bullock hearts excised, he devised various experiments to figure out how the valves work, the mitral valves, the aortic valves. So he was interested in the function of the heart structures, not just the form of the heart. And he came up with these sort of experiments, which showed that by putting fluid through the aortic valve, the flow then went up the aortic wall, came back down and added, and then closed the semilunar valves, valve leaflets, very, very efficiently. And Keel pointed to the fact that when you look at Leonardo's diagrams, you could see perhaps this maybe represents a bicuspid aortic valve, and this maybe represents a truly tricuspid aortic valve. But look in more detail. Keel pointed out that Leonardo observed in his immaculate drawings, detailed and accurate drawings, the crinkled edges of the leaflets of the valve when they close. And this is represented, when Keel wrote his paper in 1952, he pointed out that it was only shown or demonstrated by color cinematography back in 1952, the same year of Keel's publication, showing how the semilunar valves, as they come together, the edges sort of crinkle up. And same investigators, Macmillan and Matthews, went on to show the pulmonary valve by cinematography, and also showing the bicuspid aortic valve and post-surgical, putting fluid through how the repaired bicuspid valve opens up and the tricuspid aortic valve opens up. So moving on in time then, I must say that there are so many very wonderful anatomies and pathologists along the way that I can't list them all. There's Andreas Vesalius, termed the father of modern-day anatomy, because he emphasized the importance of hands-on when dealing with anatomy. In those days, anatomy was much of anatomy was learned from reading writings and looking at drawings. But Vesalius emphasized hands-on. You must dissect cadavers. Giovanni Mcalpine, of course, detailed in his book about 700 autopsies. Very, very well done piece of work. But look, both were based in the University of Padua, and that tradition of excellence in anatomy and pathology, in cardiac anatomy and pathology, is carried on these days, of course, by Gaetano Tierney, who is very well known for his work on cardiac pathology. And also running within that period of the 17th century, 18th century, wax modeling came into fashion. So this is a dissection of a heart found in the King's College Gordon Museum, where the heart is modeled because when you take a cadaver heart out, if it's not preserved, it's very difficult to handle, it gets smelly and starts to decompose. So it became fashionable to make wax models. What about the 20th century? When we come to the 20th century, we can visit Wilhelm His father, his junior, was said to have invented the microtome, and His came along and did histologic sections and then described his bundle, as we all know. Swano Tawara, his Tawara system, Arthur Keith, sinus node, discovered the sinus node, and so on. So lots and lots of very, very eminent anatomies and pathologists. But I should say at this point, cardiac anatomy is not the preserve of the few who hold the heart in hands and able to dissect them. Cardiac anatomy belongs to all of you in the audience, because I believe that it's an integral part of your practice whenever you are caring for or treating patients, especially with congenital heart disease. You don't realize it, you are doing cardiac anatomy day in, day out. Whereas I, the humble anatomist, have the luxury of just simply doing one job, which is to look at the heart, and I don't do anything else, and my hearts don't beat. So we have, moving on, in congenital heart disease, Maud Abbott, with this beautiful atlas where she documented congenital heart malformation. She was, in fact, a physician from Canada, so not a pathologist or anatomist, but beautiful atlas and with pictures, photographs documenting the anatomy. And we also have Robert Walmsley, who wrote a lot of papers on sectional anatomy. That's before the era where cross-sectional echocardiography became fashionable. Now, of course, Jesse Edwards, this beautiful, and he and his co-workers wrote beautiful atlas, including photographs of heart specimens, as well as models, wax models, made from looking and following the heart specimens in the Edwards archive. And in his obituary, and the New York Times, we have Dr. Edwards surrounded by students, very much emphasizing hands-on. Now, of course, we have Maurice Lev, Saroja Bharati and Maurice Lev, again, doing hands-on very much, having booths and stands in American Heart or American College of Cardiology meetings, and then produce an atlas with lots of beautiful photographs documenting personal experience of more than 6,300 hearts, congenitally malformed hearts. Of course, you all know Stella Van Praag and Richard Van Praag's enormous contribution to the understanding of embryology and development of congenital heart disease and the pathology, of course. And then came the era where the color photography came into being. So we have then this atlas by Wallace Mcalpine, a very clinically related kind of anatomy atlas. And in his words, my basic aim in this work is to provide photographs of dissected normal hearts for the study of details, and importantly, spatial disposition of anatomical structures using photographs. And he emphasized also the term attitudinal. So this was a book published in 1975 already. And we'll hear more of Wallace Mcalpine's work later on. And of course, we know these two gentlemen, don't we? Professor Becker and Professor Bob Anderson, from these two European giants of modern-day cardiac anatomy and pathology, from whom I learned a great deal. And I worked very closely with Bob Anderson for 25 years when he was based at the Brompton Hospital. They produced cardiac anatomy atlas using photographs, and I contributed a fair proportion of illustrative materials, of diagrams, and so on and so forth. But these are still images of normal hearts. But both of them went on then later to produce an atlas on cardiac pathology, including congenital heart malformations. Now, we move to the 21st century, or the end of the 20th century to the beginning of 21st century. We have now entered the digital age. And it's important then for us to abandon the old-fashioned 35 millimeter slides. Some of you might remember diazo slides, blue and white. And so I came along. I was invited to speak at the Cardiology in the Young Congress in 2001. And when I showed this slide, there was sort of, ooh, in the audience. And I was sort of like thinking, what's happening? Well, it seems that I was the first in the UK, if not world, to incorporate a video clip of a congenitally malformed heart in a PowerPoint presentation, a very simple method to do, and of course used very frequently nowadays. So we have here a video clip of an Epstein malformation, looking down the right atrium into the right ventricle, that atrialized portion of the right ventricle, that stuck down portion of the inferior and septal leaflet, the very, very large anterior superior leaflet, the outflow tract view, the small sort of pin, sort of keyhole orifice leading out to the pulmonary outflow tract. So there you go, a video. Now you can view the heart, not in a still image, you can view it as the presenter is turning the heart around. So William Yip from Singapore and I took advantage of the digital age to produce cardiac morphology and echo using video clips of morphology and video clips of echo. But on the research front, it's also useful to know that we're entering also the age of high-resolution episcopic microscopy, which is using a specimen, a heart specimen, fixed, preserved, and then section thin slices and capturing the image serially of these thin slices, stacking them up, rebuilding them into a kind of 3D data set. So we have here an example of aortic valve stenosis and heart with also, they had also had VSD. And these are some clips made by Hikro Matsui during his stint as a PhD student with us. So here he's turning the apex and cutting in and looking into the heart specimen. And over here, again, fetal heart, note how the appendages are so close together. The atrial chambers are very large by comparison to the ventricles, compared to the postnatal heart. And you can slice down the heart, you can look into it, and here we can see the formation of that configuration of that atrial septum, septum primum, septum secundum, and so on. And using this same sort of technique, HREM, Hikro showed that you can have transparency or translucency, and HREM shows the coronary arteries very well indeed. But concurrently at the same time, Dr. Grail, I think several of you in the audience would know him well, came up with the idea, the brilliant idea, why not scan a heart or a patient or heart model, put it through the CT or MRI, get the 3D data set, and then with 3D printing, come up with rapid prototyping. And he has indeed loaned me some of his prototypes to show at this meeting. But hands-on is very much the vogue, because the prototypes allow us to handle the specimens, preserved them. And I would like to point out that I do hands-on cardiac morphology courses at the Royal Brompton Imperial College. If any of you have trainees who want to come, just a word of caution, search for the term Royal Brompton or Imperial College or go to our website. Because like replica watches and counterfeit handbags, there are imitations around. Well, what about 3D? You've all got 3D glasses on. Well, 3D movies existed for a long time already. Avatar especially brought it into prominence. We have S3D, stereoscopic 3D. And this is what I'm going to show you. We go from Leonardo, Da Vinci to 3D, with special thanks to Gary Atrial. So put on your glasses, and let's go. This is a way of showing the heart. So I've made an endocast of a heart, not a normal heart. As you can see, it's got coronary artery bypass grafts, but it's also very useful for showing the spatial relationships of the cardiac chambers. So we turn around, we can view the side of the front of the heart, and we can note that the aorta or aortic root is sitting in the middle of heart, which I think for understanding cardiac anatomy is the very essence of it all. Where is the aortic root? Well, in front of the atrial chambers, behind the pulmonary outflow tract. Aortic and pulmonary valves are not on the same level. But we can appreciate very nicely that intricate crossover relationship between the pulmonary outflow tract and the aortic outflow tract. We can also see the small left atrial appendage, typical of the human situation, and we can see the bigger right atrial appendage. And we can appreciate the relationships between aorta, ascending aorta, the pulmonary trunk, pulmonary bifurcation, the left atrium. So if I turn now to a heart specimen, where I've injected in the left coronary system with pink and the great cardiac vein and coronary sinus with blue, we can see the pulmonary trunk and pulmonary outflow tract sitting in front of the aorta. The aortic valve, just coming into view here, and the relationship between the aortic valve and the atrial septum, which is running here in this plane. So we have then the anterior walls of the atrial chambers, the right atrium, the left atrium. We can see how the plane of the atrial septum is pointing obliquely towards the aortic root, which is important in terms of interventioning in the atrial chamber, sort of crossing from one atrium to the other, the transeptal kind of approach, needing to cross through this very thin flap valve of the fossa ovale, rather than more anteriorly encroaching upon the area termed the aortic mound because of the proximity of the aortic root to both the tricuspid and mitral valves, and especially to the plane of the atrial septum. We can also, with this heart, examine the left atrial appendage. We're looking at the heart from the front. I rotate the heart around a bit so that we can now see the mitral valve down there, a little bit of shadow. There we go. The anterior and posterior leaflets of the mitral valve, and the os to the left atrial appendage, where perhaps you might want to be putting some sort of device or plug into that os of the left atrial appendage. And we can pick up the appendage, flick it forwards and upwards, and note the relationship between the os of the appendage and the circumflex artery, which is this pink one here, and the great cardiac vein ascending and turning into the left atrioventricular groove, tucking itself underneath the left atrial wall and continuing backwards to the crux of the heart, the middle cardiac vein coming up to join the coronary sinus. But the aortic valve is, of course, very crucial in terms of interventions. We have the leaflets, in this case, a normal aortic valve closing and opening very nicely, but of course not always the case. We might come across situations where the valves might not be so nice and flexible. But if we take this sort of example and look at the aortic root from the front, by that I mean the valve leaflets plus the aortic sinuses, which are the bulging portions of the aorta. Look where the coronary arteries come off from, and here this sort of indentation expressing itself internally as a kind of slight ridge, the sinutubular junction, delineating the tubular portion of the aorta, and below it, the sinus portion of the aortic root. If we look at this aortic root, we can define a so-called annulus, a ring-like configuration at the sinutubular junction, but not really a ring-like configuration when we come to the aortic valve leaflets. And that is a point that was made by Wallace Mcalpine in his atlas in 1975. Where is the annulus for the aortic valve? In this preparation, I have taken away the aortic sinuses. This is a pulmonary valve in front here. Here's the aortic root, but I've taken away the aortic sinuses. I'm left the leaflets behind, so they're closing together very nicely. And I'm left with a three-pronged crown, like a coronet. And this three-pronged crown, according to Wallace, is the so-called annulus, rather than a sort of circular ring that one can conceptualize. So the ring situation for the aortic root exists at the sinutubular junction, and I would go on to say that there is a so-called virtual ring which exists underneath at the bases or at the nadirs of the aortic hinge lines where the aortic leaflets attach to the sinuses. That nadir, that sort of line you can draw joining the nadirs of the three aortic sinuses is not a circle, and quite rightly so, because of a difference in heights of the three aortic sinuses. They're not equal, so you cannot then form a circle. So when you're measuring for the so-called transcatheter aortic valve implants, for example, that so-called ring is more of an oval shape. Of course, bicuspid aortic valve is, in this specimen, is one of the most common congenital malformation maybe. We're looking from above. We can see the sort of ridge or raphe here, a bigger anterior leaflet with the left and right coronary artery orifices, a smaller posterior leaflet, a bit of thickening along the free margins and along the arterial surface. You begin to see the calcification, the lumps of calcification also. Whereas if you look underneath, you tend to get a much smoother surface. Okay? Now, what about congenital malformations? Because I think the theme of this meeting is really the congenitally malformed hearts. And I'm going to show you one of the heart models that Gareth Creel lent me. And here is his 3D printing of a heart with a very narrow ascending aorta. So this is an example of aortic atresia. Indeed, we see a big right ventricle. We see hardly any left ventricle at all. So a hypoplastic left heart. And I happen to find one of these examples in the Brompton Archive, similar to his model. Ascending aorta, strand-like, transverse aortic arch, large ductus arteriosus, pulmonary trunk, right atrium, right ventricle, intact ventricular septum, Where is the left ventricle? Well, right behind here. We see a small left atrial appendage, left atrium, and a tiny, tiny left ventricular cavity. In this case, there was a little mitral valve, okay? But not really functioning that well. And I think in this case, the atrial septum was practically intact. And then there's another heart that Garrett lent me. What do you think of this? Front view. Look up the right atrium, right ventricle rather. We see the pulmonary outflow tract. We see the aortic outflow tract. Through there was a VSD with overriding of the aortic valve, but very nicely demonstrated right there. The deviation of the outlet septum squeezing that pulmonary outflow tract. So, an example of phallocetralogy. But the specimen is a bit stiff, the heart model is a bit stiff, so I then bring in a heart specimen of phallocetralogy. You see the right atrium, the right ventricle, aorta, aortic valve, overriding the ventricular septal defect just there. We also see the muscular obstruction to the pulmonary outflow tract, the remnants or remainders of the pulmonary valve leaflets. We don't see that much from the left ventricular side because of the way the heart has been opened. But we can also dissect the heart in kind of different ways, and this is one of the hearts that I've made in more or less a cross-section through the ventricular chambers, just to demonstrate the substrate for subpulmonary obstruction in phallocetralogy. This is the deviated anterior calf-led deviation of the outlet septum, squeezing the pulmonary outflow tract, which is just here. And over here, we have the tricuspid and mitral valves, and down there, the aortic valve. We can begin to see the semilunar leaflets of the aortic valve and the mitral valve, and of course, the ventricular septal defect across which the aortic valve overrides. Another variant of phallocetralogy, a heart with phallocetralogy, but importantly, right coronary artery and accessory left anterior descending coronary artery crossing the front of the pulmonary outflow tract. If we can get the light in, we might just about see the aortic valve, ventricular septal defect, just a little bit dark there. And here, the pulmonary outflow tract with that deviated, anterior calf-led deviated outlet septum, and the probe passing behind the outflow tract up to the aortic, to the pulmonary valve, that aberrant left anterior descending coronary artery. And moving on a bit, we see now a model of heart with double outlet right ventricle. So we have then the aorta here, but we can hardly see the pulmonary outflow. It was, Garrett tells me, one of these little orifices, but because the model or the prototype is rather stiff, I'd rather not put any probes in to damage it. This is the pulmonary trunk with a very, very narrow outflow tract coming from the right ventricle. So double outlet right ventricle with the outlet septum just visible there. Okay? But then there's usually a ventricular septal defect in double outlet right ventricles. In this case, the defect was sitting here in the inlet portion, partly covered over by the leaflets of the tricuspid valve. You might be able to see the ventricular septal defect from the left side better. Here it is. Very nice, nicely cast in this model, a big muscular ventricular septal defect. But as you can see, this particular material that has been used to make this model is rather stiff. Nowadays, you can get the more flexible types of material that allows you to open up the heart and look in more detail. But I must say, I'm still convinced of hands-on on the heart specimens. Here we have an example from the Brompton Archive, which somehow matches the model that Gerald has produced. So if we come out a little bit, zoom out a bit, we can see more of the right ventricle here. And we also see the outflow to the aorta. Here we have the outflow to the aortic valve. Let's try and see a little bit dark, but that's the aortic valve. What about the pulmonary? Here we have the pulmonary trunk, and here a little bit of the pulmonary valve. And this is a muscular outlet septum separating aortic from pulmonary valves. There's some sort of fibrous ridge underneath the pulmonary valve and some involvement of tricuspid valve tissue blocking or obstructing the outflow to the pulmonary trunk. Well, where is the ventricular septal defect? Here it is. Just in the inlet portion of that right ventricle. And put my probe from the left side. You can see it coming through. Okay? So this is quite a similar situation as the model that Gerard has loaned me. A muscular inlet ventricular septal defect. Turning around to the left side, I think we can see that defect more clearly. Here we are. Coming through. Okay? Completely muscular borders, but the outflow to the pulmonary is a problem. Now, in terms of preparing the heart specimen for demonstrations and so on, I much prefer to have perfusion fixed when I have time, to perfusion fix the hearts before dissecting. And this is one of the few that I have perfusion fixed. Again, it is a heart with double outlet right ventricle, and we can see very nicely the right atrium, opening it up, looking into the right atrium. We see this triangular flap, the eustachian valve, the atrial septum is intact. We look down into the tricuspid valve. Now we can see the right ventricle supporting the aorta via a muscular infundibulum. And here's the pulmonary trunk. The ventricular septal defect is sitting here. I've taken away the front part of the ventricular septum. So again, a double outlet right ventricle with the VSD, ventricular septal defect, relating to the pulmonary valve. But if we look at the posterior inferior margin of that defect, it is formed by the fibrous continuity between tricuspid and mitral valves. So, to my mind, this would be a perimembranous inlet ventricular septal defect. And now we come one full circle. We come back to Leonardo da Vinci, because in one of his very many manuscripts, he describes having observed a heart with a communication between the upper chambers. So in fact, he observed a heart with an atrial septal defect. And I've got one of these examples here. The right atrium with a kind of fenestrated atrial septal defect. Here's the coronary sinus sitting just there, that hole there. But this heart has, in addition, we see the tricuspid valve just down there. But in addition, it has a ventricular septal defect just coming through here, right? You see the margins of this ventricular septal defect suggest to me It has a fibrous margin, so I would say it is a perimembranous ventricular septal defect. Looking from the left side, the left atrial appendage, down into the outflow tract, we can see the perimembranous ventricular septal defect observed from the left side has a fibrous border at the back, fibrous continuity between tricuspid and mitral valves, and note the proximity to the aortic valve leaflets, aortic valve sinuses, and the proximity to the atrioventricular conduction bundle, which is this represented by this whitish coloring, the fibrous sheath around the atrioventricular conduction bundle. But of course, in these days, you're all very much up to transcatheter interventions and, of course, cardiac surgery, without mentioning also closing an atrial septal defect with a device. So I'm going to, for the first time ever in history, attempt to do this live. Okay? So forgive me if I sort of fumble in my way around. So have you decided which orifice you are going to put your device through then? I think you would want to aim for the major orifice, won't you? Yeah? So we want to aim for the major orifice, so we're coming in with our device. Well, you would do it from the right side, obviously. And I'm trying my hardest to do it from the left side without traumatizing the heart specimen, okay? So here we are. We come through from behind. Well, I know the experts amongst the audience will say, well, she's grossly undersized this device. She doesn't know what she's doing. We can see a gap there. But no fear. That gap is covered by the left disc, isn't it? Let's turn around and see where we are in relationship to the pulmonary veins and the mitral valve. Right inferior and right superior pulmonary veins. So it's okay. It's probably okay. What about the anterior margin? That's the aortic root. Yeah? I think we want to be not causing any damage eroding outside of the atrial chamber. So I don't know. In this heart that's not filled with blood, I think I'm quite satisfied, but I'm sure lots of you are not. So with this, I would like to say heartfelt thanks to the local crew and support staff for having me here, and to MediLife, of course, for their support of 3D. I hope you've enjoyed the session. Thank you.